I want to thank the organizers for inviting me here, and it's been the past couple of years when we've done this, it's been a lot of fun. And I usually end up being the last person because diagnostics usually is the last thing you think of. No, I'm kidding. But it really is, it's fun to be here, and I think that diagnostics is probably the most ununderstood of any of the areas. I don't understand it sometimes, so I'm sure that others don't understand it either. Why are we talking about valley fever, coccidioidomycosis? That's because Arizona is the epicenter, is the highest concentration of cocci in the world as far as I'm concerned. And any trip between Phoenix and Tucson, you take your life into your own hands unless you've already had cocci. So, and you notice Texas is way down there in terms of actual rates. Sorry, I didn't show Mexico on this one, but next time we will have to show Mexico as well. I also show this slide over and over again, not from the standpoint about epidemiology, but to remember how difficult it is maybe to make or understand the serological response in cocci. For example, out of the 100 patients that we had, 60 have no symptoms. We have no idea what the immune response is in those patients in terms of antibody response. We do know that most of them probably would have positive skin test reactions, but we don't know as far as how many of them actually mount an IgM or IgG response and for how long. So it's very difficult to say when serologies are positive, when they're negative, when they mean anything clinically, and when they don't. And that's what you have to remember. Serologies are best for diagnosis of symptomatic real cocci. By real cocci, I mean somebody that comes in with invasive disease potentially, would be in those down here at the bottom, if I can see down here where patients disseminate. There it's fairly simple to make the diagnosis serologically unless the person is defunct as far as immune response is concerned, is not mounting an immune response. But otherwise it makes it very difficult. So remember all these different compartments that we might be dealing with some of these patients. You may see a patient comes in and has very minor symptoms. You do a serology, it's negative. Patient goes away, patient comes back, you do serology, still negative. That could be because it was cocci, but it was a very quick infectious disease and disappeared before he really mounted an immune response. Skin test would have been perfect in that setting. Before you do a skin test, it's negative. After the patient has a slight response, you do another skin test, it's positive usually. But not as far as actual serology is concerned. So when are serologies or any diagnostic test in cocci beneficial? Well, the sicker the patient, the more benefit you have, of course. Patient is asymptomatic. You really don't have to make the diagnosis. But there are other benefits for patients that come in and see you, say with what looks like community-acquired pneumonia. Perhaps we can avoid the use of bacterial antimicrobial agents. We all know right now we are trying to decrease the use of antibiotics, antimicrobial agents, because of all the potential side effects and resistance that we're seeing cropping up in our communities. And don't forget now with C. diff on the way, we really want to decrease the use of antibiotics because we see a lot of C. diff activity in the community. Earlier identification of complication potentially, or decreased need for added extensive diagnostic studies. If we know what it is, we have a less tendency to do additional testing, additional evaluations. So all those are potential reasons for doing that. Let me show you a couple. We've been talking primarily here about disseminated cases and cases of pulmonary disease, which is what you usually see. But look, sometimes it's much more difficult to make the diagnosis, like in this patient, which was a woman that came in with an abscess on her buttock. That's the only thing she presented with, an abscess on her buttock. And when they drained the abscess, they found it grew out coag-negative staph in small numbers. Now, being a microbiologist, I would say that's junk. That's nothing. That's skin contamination during collection. However, because you got that in a normally sterile abscess, many clinicians will say, that's causing the disease. And so that patient was put on cephalosporin. Was sent home, did okay because the abscess had been drained. Well, patient came back in, and the abscess had reformed and became fluctuant. She was seen again, abscess drained once more. This time the specimen was submitted not only for routine culture, but for fungal culture. And that was the point that was made here. This time the pus was, no WBCs were seen, I'm sorry, there were a lot of WBCs, but no organisms were seen. And that should tell you something. If we see no organisms and lots of white cells, hey, there's an issue here. It's a fungus, it's something else. It's not routine bacteria. And certainly fungi grew out, and this one it was cocci. Serologies in this patient were positive. IgG weekly for IgM, that means it was kind of waning already. Patient had a recent history of infection, but was waning. The CF titer, complement fixation titer, was 1 to 16. Not too high, but it wasn't low either. So that was a pretty good case of cocci that was determined. One thing I think I need to tell you on this case too is serologies can go up and down. In this case, this was probably a case of disseminated cocci, which had localized. The patient actually was able to stop the cocci progression in the pulmonary region, but what happened, she was fungemic. A lot of these patients are fungemic, which then that fungemia disappears. But she remembers that prior to this infectious process, she actually had a bad case of coughing and pneumonia-like symptoms about 6 weeks prior to this abscess appearing. And during that time, she slipped and fell and had a hematoma on her buttock. So what happened, it was the fungemia landed in the hematoma. Now we have a petri plate, basically, in her buttock, which she wasn't able to take care of, and we had an abscess formation. So, cocci, very quickly here. Again, southwest area of the United States. The interesting theory is that it is a dimorphic fungus, but unlike histo or blasto, it really is not thermally dependent like histo and blasto. It really is more dependent on environmental location inside the body, in other words, not as far as temperature. You don't increase temperature and it becomes a mold-like item, or decrease the temperature, it becomes fungus again, a mold. So this is what the entity does. In the environment, it basically grows as a mold. It is very, very rapidly growing in the appropriate conditions. It cannot compete with other organisms. There was a question asked about agriculture. You take cocci and you put it into an area that has other bacteria and other fungi, and it'll disappear. So in a good agricultural situation, you don't see a lot of cocci in the soil, unless, of course, you don't grow anything and you're in say, Arizona, you haven't watered for a year, the other organisms die out, that's when cocci grows. It loves the summer heat because of its arthrochonidia, the spore that it has a very, very heavy outer coating which protects it from the sun. And when the sun beats down on the earth, the desert soil, it kills off most of the bacteria, allowing this organism to propagate very quickly as soon as it rains, because it has no competition in the upper portion of the soil. And then the winds come and disseminate the arthrochonidia, which become the actual infective entity here in most cases. And then it goes into the patient or the organism that's inhaling it. In the patient, it changes its format and it becomes a spherule with endospore formation inside the spherule. Once this spherule breaks open, each endospore can go on and then disseminate throughout the body. If the patient or anybody or anything dies or gets back into the environment, it switches very quickly back into mycelial form and does not grow as spherules or endospores. This is a picture of the actual arthrochonidia. You can see the arthrochonidia, very barrel-shaped, very heavy-walled, with what we call disjunctor cells, which are actually very weak. Any amount of air, and it disseminates. So it's perfect for dissemination. discrimination.